From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA podcast. I'm Dr. Kirsten Bibbins-Domingo, and I'm the editor-in-chief of JAMA and the JAMA Network. I'm joined today by Dr. Michael Silverstein, who is the George Hazard Crooker University Professor of Health Services, Policy, and Practice at the Brown University School of Public Health. Dr. Silverstein is a pediatrician and the director of the Brown University's Hassenfeld Child Health Innovation Institute, which is charged with eliminating health inequities in pregnancy and childhood for Rhode Island families. Dr. Silverstein is also a member of the U.S. Preventive Services Task Force and the current vice chair of the task force. JAMA is publishing 2 recommendation statements from the task force on important mental health topics. One is on screening for anxiety disorders in adults, and another on screening for depression and suicide risk in adults. JAMA will also publish the evidence reports on which the task force recommendation statements are based. Dr. Silverstein, thank you for joining me today for this important discussion.
Dr. Bibbins-Domingo, thank you so much for having me, and it's a pleasure for me to represent the task force.
We are going to talk about 2 recommendation statements today, and I usually start by asking for a high-level summary of the findings of the task force. So let's start with anxiety first. What is the takeaway in this recommendation statement? And then we'll move to depression and suicidality.
The take-home for anxiety disorders is that this is the first time the task force has reviewed screening for anxiety disorders in adults. This is a common condition that affects many adults in America. And what the task force found is that in the general adult population, which includes pregnant and postpartum persons, that screening for anxiety disorders can identify this condition early, and that when linked to high-quality mental health care, patients will benefit. However, for the older adult population, which we have defined as 65 and older, more research is necessary. And the current state of the evidence the task force found was insufficient to make a recommendation either for or against the screening practice.
So this is the first time the task force has weighed in on screening for anxiety disorders. But here the state of the evidence says that the benefits of screening, people who don't have signs or symptoms necessarily, but screening for this, the evidence suggests that the benefits outweigh the harms and that clinicians should really engage in screening. For those older than 65, there's not quite enough evidence to make a recommendation for or against.
That's exactly right.
Okay, so let's move to the high level for depression and suicide risk in adults.
The high level for depression and suicide risk is that this is a fairly long-standing recommendation, although this is the first time that the task force has combined the 2 into a single recommendation statement. And for depression, our findings were consistent with our prior work and our prior reviews that in the general adult population, defined as those who are pregnant and postpartum, the general adult population, and the older adult population, that the benefits of screening for depression far outweigh the harms, and the task force recommends it. However, for screening for suicide risk, more research is urgently needed because there's just not enough evidence to make a recommendation for or against screening for suicide risk in the adult population.
Okay, so we've gotten the high-level take-home points for the 2 recommendations, but now let's step back and talk about how this actually happens in practice. So we know there's a lot of concern about mental health disorders generally among clinicians in the lay public. Some of this is greater awareness about the importance of these disorders. Some of this is concern that these have been on the rise since the pandemic. So tell me, from the task force view, both for anxiety and for depression, how common are these conditions? And are these some things that we actually see in primary care practice?
I have to take a step back and really thank you for asking the question and asking it that way, because the task force sees the mental health landscape in America as an urgently needed part of the healthcare system. And the task force cares deeply about the mental health of all people nationwide, children and adults. Anxiety and depression are very, very common conditions. The lifetime prevalence for anxiety disorders in adult women is about 40%. And for men, not quite as high, in the mid 20s. And the lifetime prevalence for major depressive disorder in the general adult population hovers around just under 10%. And that is really, really common. As you may also know, the incidence of suicidal ideation, suicide attempts, and the unfortunate suicide deaths has been on the rise in the United States over the past couple of decades. And in the past decade, it's risen almost over 30%. It's leveled off in recent years, but these are very, very common and serious conditions. The task force's new recommendations are really a real injection of good news. We have some real good and potentially effective evidence-based practices to really make a difference with these problems.
I wanted to thank you first for really giving us the numbers and talking about how common depression, anxiety are in clinical practice, that these might be on the rise. And because they are so common, they're certainly something we're going to see in primary care practice. And as you suggest, this is an injection of good news. There's something that we can do. But just to underscore that when the task force makes recommendations for screening, they're not just saying that clinicians should be alert to the presentation of symptoms. They're actually saying that the evidence suggests that we should actually be screening in people without overt signs or symptoms of anxiety or depression. And that means the evidence must suggest that we have pretty good tools to do this.
That's exactly right. One important point to make about general task force recommendations is that they apply to, quote unquote, the asymptomatic population, which for mental health conditions may be a misleading term because patients could be symptomatic. The clinician may not know it. So I kind of think of it as either asymptomatic populations, or in the case of mental health conditions, maybe non-treatment seeking populations. And what that points to are two things. One, exactly what you just said, that there are valid and reliable, high quality, accurate, and I might add, efficient screening instruments that clinicians can use to identify patients who don't present to the clinician's office with symptoms. The other point I think that's important to make there is that it's a call to primary care providers to be proactive in identifying patients with anxiety and depression. And by proactive, I mean that there's a number of patients who will present to primary care, both in the child and adult population, who don't bring up symptoms of sadness or symptoms of anxiety. What the task force found was that by proactively screening every child or every adult in this case, and following those screens with linking patients to evidence-based services will lead to benefit. So it's a matter of having the tools, as you say, but it's also a matter of being proactive in our screening.
I know in my own practice, I'm a general internist, that this is something that the nursing staff has already oftentimes done for me before I start to see the patient. So I will already have this information, or in some cases, if that hasn't happened, it's something that we've incorporated into our practice flow so that we do it systematically across the entire adult population, because the task force has made this recommendation for depression for some time.
I think that's a critical point. And as you may know, the task force has a fairly rigorous process by which we elicit and respond to public comments. And one of the comments that was very common when these recommendation statements came out in draft form was the systems in place and the facilitation of screening. And you had mentioned that in your practice, it's the nursing staff. In other practices, it's built into the electronic medical record or something that's offered to patients with pen and paper from the front desk. But one really important point is that we have to think about the systems we practice in, and are they set up to allow for this systematic universal screening of our patients? And I think that is a really critical issue for the practice of primary care.
I love that you've underscored a number of different ways that one might accomplish this, especially if we want it to be systematic across all of our adult patients. I also heard you really emphasize the word efficient, which means that really the tools are there to be able to do this in a busy primary care practice if we think about the workflows within that given practice. I want to give you the opportunity. So I said we've already been doing this for depression because the task force has had that recommendation on the books for a while. But you do have a new recommendation statement for anxiety, which suggests that there are tools now that we should newly be incorporating into my practice for screening for anxiety as well.
And for that, there's a lot of overlap, at least conceptually, with screening for depression. And one of the reasons the task force looked at these together this time is we really kind of took the angle of the practicing clinician and the patient. You wouldn't necessarily screen for anxiety in one visit and depression in another visit. These are probably things you would do, pragmatically speaking, together. And so where there's overlap is that the screening instruments for anxiety disorders, really, they ask different questions from the screening instruments for depression. But in terms of length and complexity, how many questions, and what to do with the responses is very, very similar. And so I think that's another shot of good news is that so long as the systems are in place, these things could probably be done together. I think where it's different is anxiety disorders are a very heterogeneous clinical collection of disorders. And it could be that primary care clinicians have different levels of comfort treating different subtypes, if you will, of anxiety. So I think when this recommendation statement comes out and it trickles through practice across the United States, I think it will bring up a lot of interesting and important issues around the ability to provide evidence-based care for anxiety in primary care venues and what types of patients with what types of complex conditions and potential comorbidities will get their treatment in primary care versus specialty care. And I think there's a lot of implementation issues around that.
Right. Speak a little bit more about that. Screening, of course, is just the first step. The only way screening actually improves outcomes is if it results in then another additional action that hopefully will get the patient the type of treatments that are necessary. To talk a little bit about both for depression and anxiety, the types of interventions that can actually improve health outcomes once people are identified.
I think you said it perfectly, that screening is really the first step. And screening alone really has a limited ability to improve patient outcomes for just about any condition. It's really then what happens after the screen. And for the task force in the depression recommendation had a long-standing phrase that it would say over and over around screening happening in practices with systems in place to confirm the diagnosis and provide high quality services. And those services could be provided within the four walls of a primary care practice. It could be provided by referral to specialty care. But what's really exciting to me as healthcare evolves, there's been a lot of really creative, highly effective ways of re-engineering parts of primary care practice to integrate mental health treatment within primary care, allowing primary care practices to sort of extend the boundaries of what it's able to do in the mental health space. And to me, that's really, really exciting. And I'm looking forward to the downstream effects of the anxiety recommendation to help the healthcare system along to find ways of providing accessible, high-quality treatment for anxiety based in primary care.
Yeah, very interesting. I mean, just the numbers that you're talking about with the high prevalence, the fact that this is a new recommendation, it's challenging in the fact that it is a heterogeneous set of conditions, but the real opportunity to think about having an impact, I think that's a really exciting piece about this new recommendation. And of course, it will have challenges in how individual practices and health systems decide to implement, but I think it's exciting to think about the opportunities there.
I completely agree. It also brings up very important issues around health equity because it will be very, very important that the recommendations around depression and anxiety screening and the downstream deployment of treatment services be accessible to all populations. And I think we have to keep in mind as we move forward, these recommendations get implemented across the country, that it's very important to keep an eye on issues of accessibility and equity.
I want to turn to a part of the recommendation statement that I know has already received a lot of attention and discussion, and that is the I statement, meaning there's not sufficient evidence to make a recommendation for or against screening for suicide risk. Tell me a little bit about why this is an I and what this means for us in practice.
The rising risk of suicidal thinking, suicide attempts, and the dreadful outcome of death by suicide, I can't overstate how important that is. And although the rates have leveled off, they have not leveled off in all populations. It continues to rise among African American populations. In looking at that particular issue, both from an equity standpoint and from a general population standpoint, what the task force does is squarely looks at the evidence. And one of the unique aspects of the task force's way of conducting its work is that it looks at both potential benefits and potential harms. And as serious as this issue is, unfortunately, we just didn't find the evidence that intervening among patients whose suicidal risk is detected from screening leads to what we call a net benefit, where the benefits outweigh the risks. And for this particular issue, it really underlines looking at both benefits and risk. And in that risk-benefit equation, unfortunately, there just wasn't enough evidence where we could make a determination one way or the other.
So one complexity here, of course, is that some of the screening tools for depression identify suicidal thoughts. They're contained within that screen. So how should I think about that in clinical practice? Since you are telling me on the one hand to screen for depression, which might include a question about suicidal thinking, how should I think about those two together?
Excellent question. The task force did actually look at the evidence for or against those sort of like single questions about self-harm or suicidal ideation that are embedded in the existing depression screens. And unfortunately, we didn't find evidence either for or against using those. And it really is an important area of future research. I will make a distinction, though, around identifying patients who don't present with that or share that with their clinician. Oftentimes, when you identify depression, knowing that suicidal thinking and suicidal ideation is part of that condition, that it then becomes sort of part of high quality care for patients with major depression to continually assess for suicidal risk. The task force didn't review that because that really gets more into the treatment space than in the prevention space. So I think it's a really important frontier for what continues to be unknown around those single questions that are embedded in more broad mental health screening instruments. And unfortunately, not enough evidence there either.
Just to underscore, this is not speaking to what clinicians should do if a patient comes to them concerned about suicidal ideation, suicidal thoughts. That's not what we're talking about here. We're not talking about when we identify depression that might include suicidal thoughts. That would be part of the treatment and the spectrum of symptoms that we're thinking about in treating even when we screen for depression. Nothing about the I statement speaks to a clinician intervening in either of those cases. That's very clear that we should be intervening.
That's exactly right. If a patient comes to a clinician's office and expresses thoughts of self-harm or suicide, absolutely, that becomes a treatment question or a referral question. That's sort of outside of the purview of the task force. Extremely important. But the statement of insufficient evidence does not apply to that situation. And you're right, it also does not apply to patients who already have depression or anxiety or any other behavioral health condition that in and of itself is a risk for suicide. We're really talking about the quote unquote average risk patient who comes into the primary care venue and screening that particular person with no other risk factors per se for suicidal risk.
So what the task force is saying in the I recommendation is really speaking to the urgency of developing high quality evidence that can really speak to what we can do in clinical practice routinely across all of the patients that we might see in clinical practice to identify those who might not be presenting with overt symptoms, but that we might be able to use in practice to help identify and guide them towards treatment. And right now, what I hear from this recommendation is that we don't quite have the tools and the evidence that those tools work to do that.
That's exactly right. And I would add to that, at least in my opinion, there's no topic more important that has a more urgent research agenda than potentially finding, quote unquote, asymptomatic patients who have suicidal thinking and intervening to prevent the devastating outcome of suicide. So that it's an urgent research agenda, and the task force cannot emphasize that enough.
Great. Thank you for saying it that way. I know the I statements can be frustrating. So is the lack of evidence, frankly. And for some things like this, it's important to really underscore that we need high quality research filling the gaps here so that we can intervene more routinely in clinical practice in a way that might help patients. Give me a sense of other gaps that you'd want to highlight, and then we'll have the opportunity to wrap up. What are the other gaps? We've talked about the need for research on suicide risk. What are the other gaps that the task force is really calling for more research on?
I think the other really important space that we need more information in is anxiety screening and treatment for screen-detected persons who are 65 and older, generating a more robust evidence base with more research in the older population for anxiety disorders is critical. Also, point out two other frontiers for research. We alluded to it before in our conversation, Kirsten, is around what next after screening. What are the optimal systems that a primary care venue can deploy after a positive screen? And I think we know generally this technique works well, this other technique works well, but this is a really important space where the task force would love to see more evidence around what are the optimal systems in place for screen-detected patients in primary care. And the second one is that if you look at the literature around who has participated in the trials that have fed into the evidence review of the task force, historically marginalized groups are regrettably underrepresented in this literature. So the task force would love to see studies specifically among underrepresented groups, those populations that are often disproportionately affected by anxiety and depression.
Thank you so much. I want to give you the opportunity. Is there a final take home? What would you like us to take away from these recommendation statements?
I would like to sort of leave on an uplifting note in that for the general adult population for anxiety and depression, with the caveat of needing more information for older adults relative to anxiety, that we have evidence-based recommendations, which if implemented, will improve the public health of the United States. And these conditions are common, but they are identifiable early and they're treatable. So the news, I think, is really good that we have our roadmap of effective practice in screening adult patients for anxiety and depression.
Wonderful. Thank you so much. I've really enjoyed this conversation, Michael. I've been speaking to Dr. Michael Silverstein, Vice Chair of the U.S. Preventive Services Task Force. We've been discussing the two recommendation statements that have just been released from the U.S. Preventive Services Task Force, published in JAMA, screening for anxiety disorders and screening for depression and suicide risk in adults. Thank you so much for this discussion.
Thank you, Kirsten.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.